Hi, good afternoon, everyone. We're gonna go ahead and get started. First off, thank you for joining the Medicaid Advisory Committee this afternoon. Appreciate all those who are here, able to join in person and those online as well. My name is Jonathan Figueroa. I am a back and back support staff on the support staff and also a community engagement specialist with the Nevada Health Authority. Before we get started today, I'm just gonna go over a few housekeeping items. That way we can ensure the meeting smoothly. First off, thank you, Melina, for sponsoring today's meetings. We really appreciate it. And please keep your microphone muted unless you are speaking, which this will help reduce any background noise. And then when it's your turn to speak, please state your name clearly for the record. If you experience any technical issues, note them in the chat or rejoin using the same meeting link. For those in person, the bathrooms are located in the lobby, although you will need a key from the front desk. And then finally, we ask that everyone participate respectfully and allow others to speak without interruption. With that being said, I will go ahead and pass it over to our chairs to go ahead and get our meeting started.
Good afternoon. On behalf of the Nevada Health Authority, Nevada Medicaid Division, I would like to call this meeting to order. It is June 3rd at 1:03 p.m. and verify that this meeting is being recorded. Today's agenda for the Medicaid Advisory Committee was posted on May 4th, 2026 on nevadamedicaid.nv.gov and on May 7th, 2026 on notice.nv.gov. A revised version of the agenda was posted on May 20th, 2026. Moving on to any disclosures of conflicts of interest. A conflict of interest occurs when a member of the voting body has personal interests such as financial ties, gifts, or close relationships that could affect or appear to affect their ability to make impartial decisions. Please disclose any conflicts of interest you have at this time. None in the room. Any online?
No, I do not see any online, Chair.
Excellent. We will go into agenda item number 3, which is a roll call. Administrator Ann Jensen. Present. John Phoenix.
John will not be able to make it. He did notify me beforehand.
Okay. Dawn Lyons.
I'm present.
Dr. Todd Gray.
Present.
Sharon Austin Muffet. Dr. Mediwala.
Present, thank you.
Desiree Gomez.
Present.
My name's Casey Melvin. I'm here. Shauna DeRose. Sorry about that. It's okay. David Escamay. Kim Kahana.
I'm here.
Thank you. Sorry. Sarah Fox.
Oh, sorry. This is David Kraus. I'm here in place of David Escambe.
So unfortunately, we cannot, this is Ivy, Mac and back support staff here for the record. We cannot have a member sit in or somebody sit in for another member. So we will need to mark David as absent. But if he is able to join later on, we'll make sure to mark him as present in the roll call.
Thank you.
Thank you.
Sarah Fox. Here. Bill Simmons.
Students? Yeah.
Nam Fan.
Here.
Azraela Gravel. Kaylani Queen.
Present.
Grace Larkins. Present. Sarah Dearborn. Robert Thompson.
Present.
Ricky Robb.
Present.
Kimberly Abbott. Jonathan, have we met quorum?
Yes, Chair, we have Nick.
Right. Next, we're going to move to agenda item number 4, which is public comment. If you would like to make a public comment, please raise your hand or type public comment in the chat or enter the last 4 digits of your phone number and your name will be called on to begin. Please state your name first and last name at the beginning for recording purposes. You will have 3 minutes to speak.
One online.
Excellent.
Alexis, go ahead and unmute and do your public comment.
Awesome. Thank you, everybody. Good afternoon. My name is Alexis Marin, ALEXISMARIN for the record, and I'm speaking on behalf of the Children's Mental Health Action Coalition today. First, I just want to thank Nevada Medicaid and the Nevada Health Authority for the significant work being done to address children's mental, behavioral, and physical health needs across Nevada. Our coalition continues to hear concerns from providers, families, and community organizations regarding access to care. While workforce shortages are a well-documented challenge, we are increasingly hearing reports that provider credentialing and network participation processes may be creating barriers to access. Nevada's recent statewide health access and recruitment program, so the acronym SHARP, assessment identified behavioral health as one of the state's most significant workforce shortage areas, noting that 91% of Nevadans live in mental health professional shortage areas and that Nevada ranks among the lowest states nationally for mental health access. As Nevada invests substantial resources into workforce recruitment and healthcare access initiatives, we believe it is important to better understand whether existing credentialing, contracting, or network enrollment processes are unintentionally limiting the ability of qualified providers to serve Medicaid members. We respectfully request that the Medicaid Advisory Committee consider a future agenda item focused on provider network adequacy and credentialing barriers, including Medicaid managed care and fee-for-service provider enrollment experiences, timeframes and outcomes for credentialing applications, impacts on access to children's behavioral health services, and potential policy opportunities to reduce unnecessary barriers while maintaining high quality and program integrity. Our coalition would welcome the opportunity to participate in that discussion and help to identify practical solutions that improve access for Nevada's children and families. Thank you for your consideration, and I hope you guys have a great day.
Any other public comments? Seeing
I don't see anymore.
Okay, seeing none, we'll move to agenda item 5, which is our recap from the Beneficiary Advisory Council. That can be done by you, Grace? Yes. Excellent.
Great. Thank you. Hi, everybody. Grace Larkins from the Beneficiary Advisory Council. We had a wonderful, very robust meeting today. We'll start by just sharing that we celebrated that as of July 1, there will be dental coverage for adults. Yeah, that's a big win for Nevada. We, through our administrator's report, discussed the RFA that went out around navigators to help with enrollment facilitation. And it was reported there were 36 applicants on that, and there was an increased budget. So that went up to $2 million, which sounds like is going to be a really good resource in helping to get folks enrolled around the state. We looked over the new federal HR1 rules, and specifically the work education volunteering requirement that we've all been discussing. Looked at how is compliance to be reported and documented. In 2027, it will be mostly self-reported, but needs to be some things in place for 2028. We also looked at the public-facing outreach that will go out to those expansion population that are expected to need to provide that documentation. So we reviewed those, the physical mailer, email, text, what that language is going to look like, and kind of judging the clarity of that and the best way to put those out, and gave some feedback on that. We talked about, One potential solution on that was to really kind of set some dates with the individuals. If giving kind of an end date goal, if you have not provided the compliance, or the documentation by this date, maybe prompting them to meet up with a caseworker or potentially even a QR code with those navigators that may be in place to help them to get into compliance with that. We got updates on the state legislative bills that we are currently looking at, knowing that the next biennium is right around the corner. The Medicaid Express, we found out that is set to launch this fall at open enrollment. The outreach strategy that we discussed, those are going out in October. I wanted to mention that. And we reviewed the Medicaid satisfaction surveys. Those are for the recipient satisfaction surveys that are currently going out. We had requested a little bit more information on if we had something in place and moving forward. So we were able to have see a sample of exactly what's going out there currently and give a little input on how that might even expand going forward. And so that we can collect more data that's specific to different regions or different issues and delays and things. And the last couple of things we were talking about for the future for us to look at were related to vaccination, some of that public facing language in forms and materials, an update on SB 185, the paid family caregivers for medically complex children, where that's sitting, the MAVID application, just kind of looking at the usability and guidance on that. And also we've talked in the past as well about having some guest or subject matter experts on some key areas that we'd like to discuss more. And those two that came to the top of that is in mental health, as well as in the work education volunteering requirement space, potentially Employ Nevada, to learn more about some of the job training and some of the support that they'll have in place for us.
Excellent. You guys had a great meeting this morning. I was able to listen in and lots of things were covered and really good feedback and quite a good workshop. Thank you for the update. We'll keep it moving to the agenda items 6 and 7, where we will discuss the March meeting minutes and vote on these minutes.
Chair, really quick before you proceed to that, they just want the record to reflect that Kimberly Abbott was able to join.
Oh,
Thank you, Kimberly.
yes, sorry, I was late.
No worries. Thank you. And you go ahead and proceed.
Excellent. Welcome. Thank you. All right. Meeting minutes were sent to council members on April 16th, 2026 via email for review. Is there any discussion on the minutes at this time? All right. You can. A motion for approval for the minutes.
Motion.
Second. Do we do a vote? I can never remember if we do a vote. Okay, Jonathan, will you call through everybody and we'll vote?
Oh, shoot. Could you possibly do like a verbal yay or nay? All those in
Yeah.
favor?
All those in favor?
Aye.
Aye.
All those opposed? The motion passes. We'll keep it going. I'll turn it over to Dr. Mediwala, our chair.
Thank you. Thank you, Casey. So we come to agenda item 8, the administrator's report, and I'd like to introduce Medicaid Administrator Ann Jensen to provide her administrator's report. There will be a time for questions or feedback after the report.
Thank you,
Ann,
Dr.
turning it over to you.
Yeah, thanks, Dr. Mediwala. Good to see you all. Thank you for being here in person. For those that have made the trip, thank you for those up north that have made the trip down. And those local, it's great to be down here and to see you all. And good to see our virtual team as well. So as Grace shared so well, we had a great meeting this morning. And so I'll beg forgiveness for the team that was there. I'm going to be a little bit repetitive, but as always, want to use this time to really help focus on what's important in our Medicaid world right now. What are we really focused on, especially heading into the next quarter? So those three things are, as always, we'll do our top three. Number one is federal legislative implementation, primarily in our eligibility and enrollment changes that go live this year and next. Our next agenda item is on that exactly, so we'll get into depth there. Number two is on our state legislative side. So we've got feet in both worlds, both implementing items from last session and preparing for next session in our budget, so I'll touch on that. And then our third item is on children's behavioral health. So on the federal side, as I mentioned, we're going to go in depth on what those eligibility changes are. But no, this remains a top priority for us. We got guidance from our federal partners on Monday related to the work and community engagement requirements. It's about 378 pages, I believe. And so I've been doing a lot of reading this week. But fundamentally, I think it aligns with the approach that we've been taking so far and kind of provides further clarity on where the federal government is expecting us to land on a couple of those policy decisions. So we'll talk about that, but that remains of utmost importance for us as we're developing our technology systems and our communications. And that's where I'm really excited for the input from this group today. We'll be talking about our member notices. We had a great workshopping session this morning about kind of edits and tweaks and framing, and I'm hopeful for the same from this group this afternoon. The intention is really communicate about all changes in our Medicaid program as clearly and effectively as possible, and we really need your input, and that's where we lean on your expertise. So grateful to everyone's support on that front. Second item, as I mentioned, is on all things state legislative session. We're about 60% implemented from last session of those 34 bills, which is great. Those will continue throughout the next really 3 years. We have some effective dates that are pretty far out. I don't believe we have any specific legislative implementation agenda items today, but I know that is of continued interest from this group. We'll be talking about the medical respite and fertility preservation 1115 waivers with our excellent benefits coverage team shortly. So that really ties into our state update there. We're also preparing for the next legislative session. So as folks know, Nevada budgets on a biannual basis. So we're preparing our proposed budget for the upcoming biennium starting in July 2027. It's a long time ahead to plan for, especially when things change so quickly. So a lot of time and thoughtful preparation goes into that. We're about 6 months into the process, and we have 6 months to go until that budget is formally released as part of the governor's proposed budget at his State of the State address in January of 2027. So a lot more to come on our updates there. Those will remain confidential until that time, but we're more than happy to talk about it after they're made public and know that our teams are hard at work to really ensure that the additions to our program that we're planning are aligned with our overall goals and addressing needs right now. So thank you to our full team for their hard work on that piece. That's our state update. So we talked about federal, we talked about state, and as always, we'll talk about children's behavioral health. So a lot of work being done right now to both build towards a long-term system that works best for kids and families, and also help people right now that need access to care and high-quality services at home and in their communities. We received legislative approval for 4 new positions on our Medicaid team to help support both the long-term and short-term goals. We have, I would say, about 50 to 60 staff that are working on items related to children's behavioral health on nearly a daily basis. So this remains a huge area of focus in addition to everything else those staff are doing. And so those specialized roles will support both our delivery system development as well as our specialized care coordination team. So we have a team, 2 people up north, 2 people down south of licensed clinical social workers and nurses that are specially trained to support kids and families navigating our behavioral health system, including kids and families, our kids leaving juvenile justice detention as well. So making a note here that if folks have folks in their lives that need help or access to some services, please reach out to our care coordination inbox. If a child or family is covered by one of our managed care partners, that team works incredibly closely with them to ensure that we can help access and ensure that their needs are met. So Know that we're working hard in the short and long term. We have our children's behavioral health working group that meets every other month for 90 minutes. So if you just want extra time with us, we'd love to have you. That'll be next Thursday afternoon. We'll be talking, our independent reviewer for the Department of Justice Settlement will join us to give a little bit of a debrief of her time in Nevada last month. We'll also be talking about the development of a center of excellence for children's behavioral health. How do we help equip providers with the training and resources they need to help care for kids with complex behavioral health needs? And we'll also be talking about care coordination. So if any of those are of interest to you, please do join us and know that that will remain a top area of focus for us for many years to come. And I'm grateful for the attention and support of this committee here. So I'll pause at that point after a run through of those top three. Any questions on those items that I can speak to here?
Okay, we'll keep it going. We are on agenda item number 9, which calls for federal legislative updates. So I'd like to reintroduce Administrator Jensen and Public Information Officer Chloe Chism with the Nevada Health Authority to provide these federal legislative updates.
Thank you, Casey. Yeah, you get to hear from me a little bit longer. So thank you, guys. Chloe will be sharing her screen shortly. Chloe is our public information officer and my partner in crime on all things communications about our changes. Today's presentation, we're going to start with an overview of what those changes are and what those policy decisions are so far. And then I'm going to turn it over to Chloe to present a little bit more about how we're organizing our member outreach and community education efforts. And then we'll move to discussion to get your feedback on those notices that you all received over email. Would love to hear feedback on what feels clear and helpful, what we can further clarify. Recognizing these are significant changes for some portions of our patient population, and we want to do our part to communicate about those really clearly. So with that, I'm going to go ahead and dive in. We'll start with a little bit of a who, what, when, where, how. So this is the who. Our total Medicaid population right now is about 760,000 people. About a third of those patients are part of our adult expansion population. That is a group of people for whom these federal changes apply to. We'll talk about who's automatically exempt, but it is a smaller portion of our overall population. Of that population, we think about 150,000 people are going to have to submit documentation to maintain their Medicaid coverage that shows that they are actively meeting work requirements. I'll talk about what actually counts as compliant there, but we do expect about 150,000 people to do that. The point of the triangle there is when we're intending to be as small as possible, which is to say how many people actually have to submit information that we don't already have access to as a state in order to maintain compliance. So our ultimate goal is to maintain coverage for people that are eligible wherever and however possible. And when we do have to ask for information, we want to do so in a really clear and consistent way. The good news is about 67% of adults covered by our Medicaid program in that expansion population already have a full or part-time job. So for those people, it's more of an exercise of ensuring that the state has documentation of those activities. There will be others that may need to secure a job or begin an education program or a volunteer opportunity in order to maintain their health coverage throughout 2027. So a bit on the next slide, I have more detail on who's exempt, right? Who does this not apply to? So again, it's adults ages 19 to 64. So children and seniors are automatically exempt. Adults in that age range that do not have children that have young children, ages 13 or younger, are also automatically exempt, as are pregnant individuals, people with disabilities, and those on Medicare. So once we remove those exemptions, that's where we get to around that 150,000 person number. I will note that 387-page guidance that we got from CMS this week speaks to a lot of these components. And so I'm hopeful we'll have some updated numbers soon on what that looks like. But that's our initial estimation right now. So if you move to the next slide, we'll talk a little bit more about the what. So we talked about the who, this is the what. There's 3 changes for this population, that adult expansion population. Firstly, for people that are newly enrolling in Medicaid coverage or renewing their existing coverage on or after January 1st of next year, they're going to have to meet these work and volunteer requirements. So we'll talk more about exactly what those are, but at a high level, 80 hours per month of a qualifying activity. Additionally, that same population, instead of renewing their Medicaid coverage every 12 months, it's going to be every 6 months. So it's a more frequent redetermination process. And during that redetermination process is when the work requirements components come into play. So those two things are pretty linked, and that will begin for renewals starting after January 1st. The third piece that's a little bit into its own bucket is our cost sharing or co-pays changes. As folks probably know, Medicaid coverage right now is zero cost for nearly every single member. There are a couple populations that pay small premiums to be part of the program, but for the most part, it's a no cost program. That will change for some people, for some services, starting in October 2028, so over 2 years from now, in which providers will be required to collect co-pays of at least $1 for some services and for some patients. You'll know that that's pretty vague. That's because we don't know a lot yet about exactly how the federal government is going to expect us to collect that information or to make those determinations. So we expect the next 400-page guidance letter to be about this one, and that will come likely later this year or early next. But want to make sure that's on the radar because that does impact this very same population. Yeah.
Came out, but for the record, can I just ask, these new requirements only apply to the expansion group,
Correct.
not to existing Medicaid recipients? Is that correct?
So it's a portion of existing Medicaid recipients. It's about that 270,000 people on our program right now. Those three changes will apply to. And they're called our expansion group because of the way their income is calculated, but it's basically adults on our program. Yeah. Yep. Good question. Interrupt me anytime. This stuff is complicated, so please do. We'll move to the next slide here. This is a little bit more about the what in terms of what actually counts. So how am I allowed to be compliant? There's a number of different activities that fall into three main buckets: working, being in school, and volunteering. A combination of those three things, you have to meet 80 hours per month, so between 15 and 20 hours per week, or earning at least $580 per month, including on an average basis if that's seasonal work. We recognize our employment landscape in Nevada is really unique. There's a lot of shift work, there's seasonal work. It's more complicated than some other industries. And so we're working to secure as much flexibility and clarity in the requirements from our federal partners to ensure that people know what types of activities will count. In the work bucket, we have employment, so a standard work, but also apprenticeships or trade programs. We recognize for seasonal work, people may not be paid on a regular basis. An example I was discussing with the Medicaid director in Oregon, they have a big hazelnut industry in the state of Oregon, and hazelnut farmers get paid once per year. So the question is, how does that count, or what's the calculation there? So, well, we may not have as many hazelnuts. That is applicable to people in our population, and so there's a lot of really complex kind of guidance from CMS on how we can calculate seasonal work. Additionally, that volunteering would be the same number of hours per month, and school means at least part-time education, and there's some more detail on what types of education counts. So it can be a mix and match. And I'll note the policy decision that Nevada Medicaid has made based on our flexibility that we have is to do a look back period when folks renew or apply for coverage. And people only have to meet these requirements for 1 month in that look back period. So if you're newly applying for Medicaid, say in February 2027, it's a 3-month look back period, and you have to have met these requirements for at least 1 month in that look back period, meaning in November, December, or January, you have to have met these work requirements in order to enroll in Medicaid. If I'm renewing my Medicaid coverage, I'm a current recipient renewing coverage in February, it's a 6-month look back. And it's also, again, 1 month in those past 6 that you have to meet these requirements. So it gets complicated. We're trying to find clearer ways to talk about it. But any questions on the what counts and how we look at that? Okay, let's keep moving. So this next piece is, how do we know if you've done those activities? So first and foremost, there's kind of a hierarchy. We are required to look at all available data that we have to firstly identify if someone is exempt or compliant to using data without having to ask them for anything. The next level of that hierarchy, in 2027, we're allowed to ask for a self-attestation, meaning someone can complete a screening tool that says, yes, I am compliant with these requirements, or yes, I am exempt for this reason. For the first year of this change, that will be acceptable on its own. Starting in 2028, we're going to have to ask for documentation first, meaning a doctor's note that demonstrates that someone can't work, or a kind of pay stub or hourly time log from a volunteer opportunity, for example. Whether it's attestation or documentation, everything has to be auditable. And CMS will come audit every state's compliance here. And so folks will be asked to provide documentation that they're meeting this. So those are kind of the hierarchy and what we're allowed to ask for. Our intention, again, is to make that data component as robust as possible. So we're limiting what we're asking. But it is true that we will have to ask people for information to be able to maintain their coverage when they're renewing or enrolling in Medicaid. We move to the next slide.
Shannon,
Yeah, please.
sorry, this is now then. So for the screening tool, you said someone may complete a screening tool. Are we allowed to maybe get like a vendor to help a member do the submission?
Good question. So the member has to be the one that attests to the screening tool itself, but we recognize people are going to have questions as we go through the process. So that's where our caseworkers, the Division of Social Services, will help, as well as our navigators, which are people that are community organizations that receive training and funding from our health exchange to help people through the insurance process. They're going to be trained in these rules. Both the caseworker staff and the navigator and health insurance exchange staff will all be trained in this, so they'll be able to support. The screening tool itself is part of the Medicaid application or renewal packet, though, so it has to be completed by that member or their legally authorized representative. So they can get support or ask questions through the process, but they'll be the one to complete it. Yeah, good question.
Thank you.
Yeah. Okay. This is a little bit more detail on the exemption piece. So folks that are not required to go through this process, we talked about children and youth, foster youth and former foster youth, parents of young children, seniors, people that are pregnant or postpartum. Additionally, all tribal members are automatically excluded from these requirements, as are veterans with total disability and people who are also covered by Medicare. There's 3 other categories of exemptions, and this is really what that federal rule is focused on. So you may have seen things in the news about this. The top right is under a category that CMS terms medically frail. And that medically frail definition is really tied to having a medical condition or a behavioral health condition that impairs or limits someone's ability to work. And so that's the way the federal government is interpreting it. It's not just that you have a diagnosis, but it's also that it's linked to a challenge or inability to work itself. We're working to update our definition based on that guidance from our federal partners that we got earlier this week. And again, our intention is to use claims data and other information, as well as kind of notes from a doctor where needed to demonstrate that connection to inability to work. The other component is about someone's situation. So you may be exempt if folks are incarcerated or recently were released from incarceration. People that are caregivers of persons with disabilities are also exempt. And there are work requirements in the TANF and SNAP programs currently. So if folks are already meeting and they're already compliant with that, we're not going to ask them to go through the same process for Medicaid. We can just accept that and exempt them moving forward. The last piece, and this is a state decision point that based on feedback we've gotten from our community, we plan to move forward with opting into a 4th bucket, which is called our short-term hardship exemptions. Those are if someone lives in a county where there's a natural disaster, high unemployment rates, recently hospitalized, or that they have to travel for healthcare. All of those things would temporarily exempt someone from work requirements in that kind of renewal or enrollment cycle. So 4 categories of exemptions. We have a better picture of what this looks like now that we have guidance. We're digging into that and making sure that our path forward is very clear and folks understand what that looks like. Yeah.
Got a question.
Please.
Grace Larkins for the record. On that state decision point for short-term hardship exemptions, what is the next step in seeing where that goes? If we're going to go with it or not, is it being brought up? Yeah. Where's the decision happening?
Yeah. So we had a public workshop in March where we brought this forward and said our intention is to accept this, but we want your feedback. All the feedback was resoundingly thumbs up, please accept it. And so we were just waiting for the final guidance from CMS to make sure that that was still an option. It is, so we will be moving forward to accept it. Yeah. So no real decision needed at this point. It's essentially already complete. Yeah.
Thank you.
Yeah, good question. Okay. That is a lot of policy detail and this gets wonky fast. So thank you guys for bearing with me. We're going to now shift to talk a little bit about how do we communicate about these? Incredibly complicated. We don't have 20 minutes to sit and walk people through different slides to talk about these changes. How do we spread the word and also work directly with people for whom their coverage is changing to make sure that goes as clearly and effectively as possible? So excited to turn it over to my colleague, Chloe, who will be walking through our approach here. And then we'll open it up for discussion. So get prepared to give us your feedback at that point. So Chloe, all you.
Great, thanks so much, Anne. And hello, yes, my name is Chloe Chism. I am our Public Information Officer at the Nevada Health Authority. And so I have been working with Anne and our amazing team to really push forward this effort to work on outreach, education, and communication to our members and their communities. So I'm really looking forward to this being a collaborative discussion. Please feel free to ask questions at any time. I'm looking forward to your feedback on our overall strategy, how we are planning to engage our stakeholders, our messaging and timelines, and really excited to dive in. So I will start off with just an overall kind of high level review of our strategy for communication and education and member outreach. And so I would say our overarching goal, that is to ensure that information about these new rules and requirements reaches our members clearly and effectively. So steps to go about that. We really want to help folks understand, bottom line, what is changing and what they need to do to retain their coverage. We know that's the bottom line for everyone who is in this population. We really want to focus on clear and consistent messaging that reassures Nevada Medicaid members. A big piece of this plan is to partner with our community organizations, our navigators, as Anne mentioned, and really just trusted messengers in our members' communities to help us communicate in a way that reaches our members where they are. We plan to and are currently creating and distributing messaging toolkits, resources, and continuing education to our partners and stakeholders that we're working with so that they can confidently pass along this information when members come into their offices or different various locations throughout their communities. And really, bottom line, we want to emphasize support, resources, pathways to maintaining coverage for our members, and really focusing on using straightforward language and avoid confusing industry jargon, which we know there can be a lot of, and it's already complicated enough. So that's our overarching strategy. And moving into kind of how we're piecing that out, we see this strategy in mainly two separate buckets, and I'll dive into the details in these bullet points as we go through the presentation. But on the left, we have targeted member outreach, and this really comes in the form of communication and notices to our specific members who are in this adult expansion population who may have to meet new rules and requirements. So that will come in the form of mass mailers, emails, texts, maybe some other forms of communication, depending on any feedback that we get. Really want to be cognizant that not everybody has access to a computer or a phone all the time. So making sure we utilize multiple forms of outreach to get the message and the information to our members. Once we start needing more information or as renewal dates come around, renewal packets will be circulated. If we do end up needing more information, in addition to what we have on file to prove or clarify compliance, requests for information or notices of non-compliance, letting a member know that they do not currently fall into compliance with the work requirements, and providing resources of how to get back into good standing. For new members, approval and new applications, approval and denial letters, and a big focus as we approach 2027, once these do take effect, is continuous outreach post-implementation. So our job doesn't end on January 1st when these go into effect. We really plan to take a lot of what we've learned throughout our implementation process and put it into a continuing education strategy, making sure we are here for our members as these new rules take effect, and making sure that this education does make it to members who do enroll new members in 2027. So it's very targeted, probably much more technical. Moving over to the right-hand side, we have our community education piece, which really includes all of our proactive communication, marketing, education activities outside of this specific targeted member outreach that we are federally required to do. This will include public workshops. We have already hosted one in March and plan on doing at least 2 more. Hopefully some focus groups and listening sessions where we can really have conversation-based discussions, hear feedback, get questions answered, hear concerns, really looking for that ground level community feedback on what folks are hearing. Stakeholder engagement, ensuring that our stakeholders are equipped with the right messages and information. We're developing our fact sheets, brochures, resource guides, and additional printed and digital materials to distribute. And eventually our social media advertisements and marketing activities to really get the word out and make sure it is as widespread as needed so that this message and information reaches everyone that it needs to. Also, if there are hands raised, I can't see when I'm screen sharing, so feel free to just jump in if needed.
You're all good, Chloe. Thank you.
Perfect. Okay, moving forward to our timeline. So this is an overview of the communications dates that are coming up and that are really key for our members and their communities to know. So I'll start off with what's going on pretty much right here and right now. We are, as you know, developing and finalizing the language for the mass mailer notices and emails that will go out to our existing Medicaid population on September 1st. So we're really looking forward to your feedback on that, finalizing the language there. And in October of this year, there is a notice required to go out to our legal immigrant population. So we are finalizing that notice language as well to send in July so that those members have plenty of notice before that change goes into effect for that population. And also next month, all language for all notices will be translated to make sure that it's accessible for all members. So lots of communication, language finalization going on in the early months of summer. Moving into the heat of summer 2026, there will be another public workshop. We don't have an exact date for that yet, but really hoping to make it very communication focused, what folks are going to see, what they can expect, where they can go to find information and additional resources. And we're also going to initiate our broader external communications, really engaging and equipping our stakeholders, making sure that the message and information is out where it needs to be. Later in the summer, this August, we plan to launch our media and marketing activities, hopefully running some ads and just another piece of the broader strategy to communicate on this information. And moving into September is when the notices to our members will be going out. So the federal deadline is September 31st for all the mass mailers and at least one additional form of communication to go out to our existing population in this expansion group. So we will have those in the mail, emailed, and texted by September 1st to make sure that we are well ahead of that deadline and that our members have time to really learn and digest the information. Later into the fall, another public workshop, hopefully recapping on some information that we've learned throughout the process, hearing concerns, feedback, maybe implementing a different forum rather than virtual. We've discussed maybe doing an in-person community meeting or a town hall, really going to hone in at that time on what is needed and what might need additional attention or consideration at that point as we approach the implementation date. And leading up to January 1st of 2027 is when these new requirements do begin for work, school, and volunteer requirements and the 6-month eligibility redeterminations. And as I mentioned, throughout the rest of 2027 and 2028, our continued outreach and education post-implementation work begins, where we are there as a resource for members and new applicants to really make sure they have everything they need to stay in compliance if they do need to with new work requirements.
Hey, Chloe, we have one hand up, so I'm gonna just stop you right there. It's a lot of good content. Kimberly, thanks for your patience since this morning. Excited to hear your comment or question.
Yes, thank you. Kim Gahagan, Molina Healthcare. I was just wondering about tracking for the materials. It would be helpful, I know to me, as one of the managed care companies, to know what's working for the members and what's not, what they're responding to. So one, will there be tracking mechanisms? And two, will you be sharing those with us?
Yeah, Chloe, I can take that one. So great question, Kim, and thanks for being here. Yes, we will be tracking. I will note a lot of our tracking is going to really vary by mode and how granular we can get with some of those outcomes, but we will absolutely share it. And for folks that are not part of our managed care organizations, we actually have a real deep dive into this content tomorrow, I believe, on Thursday afternoon, to talk through with our managed care organizations how we'll continue to partner and find ways to give you all that real-time feedback we're hearing and to get the same from you guys as well. So really grateful for the collaboration there and definitely top of mind for us.
Great, thank you.
Yeah.
Thank you, Kimberly. Yes, thanks for the question. Okay, and kind of in the same vein, moving forward to our stakeholder engagement piece. So our plan includes utilizing and engaging a broad group of stakeholders to help us meet our members where they are in their communities. So this is very broad, but 4 of the really important main buckets that we plan to focus on are our Medicaid district offices, which are Las Vegas, Reno, Carson City, Elko. So if any of our members come into their district office to get a question answered, the folks there can feel confident that they are providing accurate and up-to-date information to the members to answer their questions. Moving on to our health plans, Health Plan of Nevada, Silver Summit Health Plan, Molina Healthcare, CareSource, and Anthem. Our navigators, as Anne mentioned, this category will expand, but we've identified several, including Dignity Health Community Health Centers, Asian Community Resource Center, Access to Healthcare Network, Nevada Health Centers, and more that will continue to be identified as we work through this new grant funding. And finally, I think a really important bucket is community organizations. So part of conducting outreach direct to our members is we want to be able to connect them with additional resources, maybe to help stay or get into compliance if they may not be at the current time. So partnering with Nevada Department of Employment Training and Rehabilitation, or DETR, Employ NV, Office of Workforce Innovation, United Way, all important resources to find work and education and volunteer opportunities as needed. I will stop there before we move into kind of diving into our proposed and current draft language for our notices together, just to see if there are any questions. Happy to answer any, if it's not a question, maybe just some feedback. Oops, I didn't mean to do that, sorry. Just some feedback if there's any at this time, or we can just move right into the notices.
If we have any hands raised right now. Oh, we do. Yeah, go ahead.
Yes, hi, Chloe, this is Nam. For the one completed public workshop that you identified, do you know what the attendance was like at that session?
And I don't know off the top of my head, but I remember it being very broad.
Yeah.
There was a
I think
great
it was
group.
a couple hundred. Yeah, yeah. But the recording is posted to our website. So we do have an HR1 website, webpage that lists all the existing resources. There's been a number of legislative presentations and others. So all the content that we've presented so far is available on our HR1 website at nvha.nv.gov. And we'll continue to be building that out with all the resources that we have in case folks can't attend those workshops and want to catch up later. Yeah.
I have a question.
Yeah.
Are there any current guidelines to which providers can provide the documentation that says somebody is exempt because of their functional limitations?
That's what we're kind of working through in the federal guidance right now. So that's what's included in that rule that came out on Monday. Is it seems the states will have some flexibility to define what providers can do that. So that's something we would bring to a public workshop to talk through. But I will note for 2027, the self-attestation will be allowed, meaning people can say my medical condition prevents me from working and testify to that. So the doctor's note component is most crucial when documentation is required in 2028. Yeah, so we have a little bit of time to develop our policy and get feedback on that. Yeah. Great questions. Any others? Okay. Chloe, let's dive in. We would love your feedback on this. I have all these notes from our back, so we're ready to hear it this time as well.
All right. So we all should have the current draft proposed language. So this is what we're looking for right now, and I think we can just jump right into the open session feedback, assuming we've all had a chance to review, but if not, we can definitely dive into a specific aspect of the notices. If there are any particular questions, I as well have a bunch of notes. I'm really looking forward to hearing the feedback from this group as well. So Anne, do you want to open it up for discussion, or do you want me to work through these questions?
I think we're up for discussion. So for MAC members, we'd love to hear from you. Hopeful that you had a chance to review ahead of time, and if not, feel free to scan now. But we want to hear from you. What's clear in these? What could be clearer? If you were the one reading this notice, if you got this in the mail in September, what would your reaction be, and how can we make that as clear as possible to know where to go?
This is Dr. Gray. I felt it was very informative and fairly clear. I'm not certain how that will be received by members, but I think you guys did a nice job in breaking down what the requirements were. It was helpful. Thank you.
Thank you, Dr. Gray. I appreciate it.
Thank you.
Sorry, Sarah, go ahead.
Yeah, so Sarah Fox, first question, kind of going back to when you explained the period and how that is very confusing, whether you're new or re-enrolling. And I'm not, this is a great document, agreed, but and maybe how can we work that in so that's a little more clear?
That's a good point.
A lot.
That's a great point. So yes, let me think about my thinking out loud here. My thought would be in the what are the requirements section, we could say you must work or volunteer 80 hours a month for at least 1 month during our review period, right? Something like that to say, hey, it has to be at least 1 complete month of meeting these requirements. My intention would be when you actually get the renewal packet or the enrollment packet, it would be a lot more clear. In the past 6 months from today, from your renewal date, we need to see something, right?
Maybe an example.
But maybe an example would be good. Yes, I like that a lot. My February example, we could pick maybe a clearer month, but something like that. Yeah. I think an example with all dates would be really clear. Yep. Great feedback. Thanks, Sarah. Yeah, Shauna. Yeah.
It's great reading level.
We have. Yes, I know. I know our PIO has, but I think we'll continue to take another look at it, because if there's particular words that you feel like are feeling tricky, sometimes those word check calculators aren't as effective as they could. So any specific feedback, I'm all ears. Yeah. Yeah, Bill.
I did have another question. Bill Sims for record. I know it does say that anyone who's on Medicare is exempt, but I'm curious because I know like if you're between 19 and 64, that you would have to meet these requirements. But as someone who is in their 40s and on Medicare, and then there's not many people in this age range that are on Medicare. But is there any way to just say on Medicare, even if you're in that age range?
Yeah.
Because I'm guessing if I'm asking that as a clarifying question, there's probably going to be maybe other people in that age range, even if they are on Medicare, that still might wonder.
Yes, that's great feedback, Bill. I appreciate it. I'm wondering in that exemptions bullet list, maybe we rephrase it to on Medicare at any age. What do you think? Would that be helpful? And then my thought is on the first page, maybe people ages 19 to 64, and then take out the does not qualify for Medicare piece, because that gets a little confusing. And instead say people ages 19 to 64 that aren't otherwise exempt or something like that.
Yeah.
So kind of point to that section. Does that make sense? Is that helpful? Because you're definitely not alone in that, and we want to make sure that's clear to people. Yeah. Great feedback. Yeah, Kim.
On the, what if I don't meet the requirements? I feel like that I want to hear more. Like I feel like, so, okay, you don't comply. So what does that mean? Right? Does that mean because then the next one is, what if I lose Medicaid? So if I don't comply, does that mean I lose Medicaid? And if so, I think it should be very clear that that's.
Yes.
And even I don't comply, apply, I'm not in compliance. I don't know. I just feel like I'm left with questions at the end of that sentence. Like, what does that mean?
That's a great flag. Yes, and I think there's a piece that we can add in for everyone's benefit here. If it's found by your redetermination date, so February 1st for me, that I haven't met that work requirements in the past 3 months, my coverage is terminated at that time, but I do have 30 days to submit documentation to essentially rectify that. And so we want to be super clear about that 30-day period, right, in that sentence. I think it's mentioned elsewhere, but we can be even clearer right there. So I appreciate you flagging that, and we'll definitely make the connection between those two sections more clear. Good feedback.
Any questions online?
I have comments. And so now for the record, and Bill, to your point, CMS actually released their findings from the April focus group. I don't know if you had a chance to see that. And one of the top 3 findings was from the focus group was members didn't know whether they were exempt or not. So I think that's a clear thing we want to probably identify. And Chloe, if you get a chance to look at it, it's actually a 4-pager if that's online. And it's basically all the results of the focus groups that they've done. I think that's one key thing we should evaluate, because I think they do talk about the second piece being communication. And even though there was extensive communication, it wasn't relevant, or it wasn't to the point where the member would be able to understand. So that would be a key. And I think the second piece is, if we take a look at Nebraska, since Nebraska went live on May 1st, I think it was a complete disaster. So we probably want to look at what they did and not follow that. Yeah.
No, I appreciate that. Or go ahead, Chloe. Yeah.
Sorry, Anne, didn't want to interrupt there, but I really appreciate that feedback. I think I will definitely take a look at that 4-pager. There's always creative ways that we can find to make sure members know if they are exempt or not. It's that I would say that that's probably one of the most complicated aspects of all of this. There are so many caveats. We know everyone's situation is unique and different. Also, situations change. So if a life situation in your life comes up or something changes that might bring you in or out of that expansion population, there's always more education and explanation we can do in that area. Or a situation that brings you in or out of an exemption. So I do think that's a really important piece, and thank you for bringing that up. I'll definitely read that finding from the focus group and make sure we implement that here. And there was one more point, but Anne, I'll let you take that one, and I will remember what I was going to say.
Yeah. No, absolutely. That makes me think even just super practically, we can move that exemptions bullet list to the who does this apply to section, right? Up top to say, hey, right? That way, if you see your exemption in that list, like, I don't have to look at the rest of this. What we also talked about this morning, which was great feedback, is making sure that exemptions list is maybe bucketed in 2 ways. One, people that are automatically exempt, and we're going to be able to see that in our data, and we don't need anything else from you. Like, this is a just FYI, you're good to go. Versus there's some exemptions where we actually do need people to submit information, or we may reach out to them and they still need to kind of follow along and be engaged. So we'll think through those pieces, but thanks for pointing us in the direction. I hadn't seen that focus group 4-pager yet, so I look forward to reading that. Yeah. Okay.
Yeah, one more question.
Yeah, please.
So this is Sean. What are the requirements? So when it talks about volunteering at 80 hours a month,
yeah,
my understanding is this is the same, like you said earlier, the requirements for SNAP, right? But where people think possibly that it's 80 plus 80.
Oh, interesting. Like, be in addition to the SNAP requirements. Yeah. That could be a point of confusion. We should maybe clarify. Yeah. And maybe we can do that. I want to make sure we have, so we already have on that exemptions list, right? Already required to meet work requirements for food. Yeah. We'll think through that piece and how to better phrase that. Yeah. Rethink phrasing. That's great, Shauna. Thank you. Okay.
And please, despite I know the NCOs have brought up to Jimmy already the idea of tying the redetermination dates to the SNAP benefit renewals. Because just from a member point of view, for the members we work with, people know when that SNAP date is. They know it, and they're on it, and they never miss it. But getting them to understand when their redetermination date is for Medicare or Medicaid is a totally different topic. So if they did it at the same time, or if they did one and it applied to the other, I just think that
Now you've tied these two very important things together. I know it's a different agency, you've got DSS, you've got different things going on, but I still think that might be a really good way to tie those together.
I appreciate that. I think you're right. Like, a redetermination date means nothing to pretty much all of us. Even those of us that go through open enrollment, that date doesn't really stick, right? So, sorry, I'm gonna go this way. But I think the piece that I want to think through is with a 6-month redetermination, it's going to be pretty hard. We can't just pick a date, right? It has to be that 6-month period. But that may give us a little leeway and flexibility to think about it. So that's I appreciate that bug in our ear. I know Jimmy's been thinking about that too. So we'll see what we can do. But in general, finding ways to communicate what someone's redetermination date is or where they can find it is going to be really key for this piece. One super practical thing we wanted to get people's thoughts on. So this is bullet point number 4 up here. What do we want to call this? Or how do we communicate about what this is? So as we know, there's kind of 3 buckets of categories that would make someone compliant: work, education, volunteering. The federal language is community engagement. I think a lot of national media, it's work requirements. We're trying to get feedback from you all. What really resonates? What actually makes sense to capture what we're describing? I don't know if members from our MAC want to speak to what our discussion was there and where we had landed, but we want to hear feedback from our MAC as well. Bill, you want to share?
Bill Jensen for the record. I personally was under the opinion we should go with work and volunteer, just because to me, to say community engagement, as someone who does a lot of advocacy work outside of just regular volunteering, to me, it just made sense to say volunteer, but then Anne did also point out, well, what about for people who go to school? Which then Kalani said her piece, if you want to talk about that.
Yeah, Kaylani Quinn, for the record, I also agreed with the work and volunteer requirements because school is essentially another form of work. So I think that should qualify. I think that should be kind of self-explanatory for the beneficiaries.
So with that reasoning, I think we had landed on work and volunteer requirements, but what resonates with our MAC team? Any initial thoughts there?
This is Robert Thompson for the record. I agree that it really needs to be work and volunteer requirements. The term community engagement is going to be confusing to this population, and it's easy to explain that the school takes the place of work, but the term community engagement is going to cause problems.
This is Sarah for the record. I was going to say the exact same thing. And the only thing I was going to say is, are we able to work in school into that? So maybe work school and volunteer requirements? Can we do that?
So we can do whatever we want. Yeah. We had talked about that, I think, and even at the top of this, like the subject line, right, we have work, education, and volunteer requirements. So we could switch it to school. I think our challenge is just like, how much space do we have, especially as we get into like social media content and, tighter words. But I wonder if our preference would be work, school, volunteer. And if we can't do all 3, we drop school. Does that resonate with folks?
Now, fan for the record, I would probably go the other way and say we should be consistent with whatever the feds have it as. Because if I'm a member, I'm just going to Google it. And if I see an inconsistency between what the feds publish, so CMS versus the state, am I going to assume that it's the same thing? It's work and community engagement versus work and volunteer. So that would be my only perspective from it.
Yeah, that's a fair point. Yeah, we should think about that. We can even do some test Google, see what comes up. I think so often it's referred to as work requirements, regardless of what language the federal government is using, that I feel like the connection would be there, but it's a good point that we don't want to add more confusion. So we'll look at that. That's fair.
I would also agree, Anne. I'm sorry. Just really quick on that last point about consistency with the federal reference to these requirements and rules. We have thought through that a little bit. We did want to see maybe what would resonate in our state particularly, but I completely see your point there. I will just bring up that the state health value strategies is also recommending to not use now at this point community engagement, because results from other states have shown that that reference is quite confusing. So really this was a big piece that we wanted feedback on, and still something that we're going to consider moving forward. But we are learning from other states. We're part of some learning collaboratives, really trying to see what has worked and what hasn't worked. And this is one point that has proven to be a little confusing in other states. So still going to fully consider that, but just wanted to bring that up for the group, just as something to consider.
Just super briefly, Chloe's being pretty humble, but she applied and got us into a very excellent national collaborative. We're one of 6 states that's part of a member communications collaborative specific to HR1, led by the Center for Healthcare Strategy. So we meet and kind of pull an intersectional team together on a regular basis to talk about things. The Hy-Vee is part of that as well. So we're super grateful to have a lot of resources to learn from, and we'll be drawing from some of that too, which is great. So, but yeah, Shauna, go ahead.
Whether we use education or school, I do think we should be consistent, because as I'm looking at it, we use both. And in some places it's one and some the other. So I think that can also be confusing.
Yes. Yep. Consistency. Okay. Super helpful feedback. Anything else beyond that is fair game? Oh yeah, we had someone virtually chiming in.
I'm sorry, this is Dawn Lyons. I just wanted to chime in for the disability community perspective. Is plain language is always best. Honestly, federal language can be confusing. It's often vague, you know, we can read into it. So just the simple work, school, volunteer requirement sounds best to me.
Thank you, John. I appreciate that feedback and agree. Plain language and maximum 6th grade reading level is our kind of standard for any public communication that we put out, and is especially important when these messages are really crucial about coverage. So thank you for that feedback and reminder there.
I have one more thing to say. Kelani Queen, for the record, with the school aspect, would somebody that is going back to school to get their GED qualify, or just higher education?
Yes, my understanding is in the guidance, those 387 pages are swirling in my brain, but my recollection was it was GED, higher undergrad and master's level education, as well as some of these kind of apprenticeship programs that may kind of fall. So there's some range there. Yeah. Yeah.
Bill Sims, for the record. I just actually had a thought just now when you mentioned school. How is that going to work in the hour? Is that counting how many credit hours you have? Or is it counting how long you're at school, during class, doing homework, whatever it might be? What's going to be the determining factor? Because in order to get 20 hours a week, you have to be taking at least, I think, 3-4 credits a semester, and not everyone is able to do that. So how's that going to work?
Great question. I wish I had that section of the rule pulled up to speak to it in more depth, but my understanding is it's kind of connected to at least part-time enrollment. So it would be, I think it's more of justification of what the kind of actual coursework hours are on a monthly basis to hit that 80 hours max.
Okay.
I'll double check that though, and we'll make sure wherever that lands, and we'll refresh our memories on that, it's super clear in our screener and all those pieces so folks know. But I think it would be anyone who's at least part-time in a school program would be qualified to do this.
Yeah, because I mean, college students aren't going to be, knowing both pieces at the same time for sure on their own.
Yeah, it's confusing for sure. Yeah, absolutely. Yeah, great.
Hi, Grace Larkins, for the record. I think we're on a great track. I absolutely agree. I think that the work, school, and volunteering requirements is really clear. Or just work and volunteering requirements yet to come. But the idea of synthesizing it kind of into the 3, like some groupings of the who, the what, and the timeline, that kind of a thing. And like, I really appreciated when you talked about putting those exemptions up more near the top. And then some of these kind of feel more like an FAQ that would be at the bottom. So it's more like the primary information is just kind of right up top. And then when you get kind of down into the, digging in a little deeper, that some of those get pushed further down.
I love that organization. So kind of the who, what, when at the top, Grace mentioned she brings a graphic design background, so we were talking about some visuals we could include. And then having the FAQ after that, I think that makes a ton of sense. Yeah, I like that. Chloe, we can play around with what that could look.
I definitely agree.
That's great.
Maybe we could also bring up a few of the feedback points we got from the back, just for the group's knowledge. And would that be okay? Okay,
please.
Great. So we discussed maybe listing or having a little more clarity on the short-term hardship exemption qualifications, where as we federally have to define this by county. So maybe it would be helpful to list the counties in Nevada that are qualified as having a high unemployment rate. I also want to make sure the group is aware that wherever you see website TBD or link TBD or phone number TBD, part of our community communication and education strategy is really building out our HR1 webpage that Anne mentioned. So in the email, there will be a live link to this website where there's more visually dynamic, maybe not so wordy or technical information that really explains all of these changes in information, maybe some data, dynamic pathways for you to find out, if maybe a quick survey. We're exploring a lot of ideas for simpler, more easily accessible ways for folks to find out if they fall into these categories or if they are exempt. And the URL will be spelled out in the mailer, in the physical mail that comes to members. So that website is under construction. It will be fully built out by the time these notices go in the mail and are in boxes. We also may include a QR code for some additional resources of how to get to this digital or online information. And maybe I do really appreciate the feedback about the 30-day timeline. We received that at the back as well, just making sure that the steps that folks need to take are very clear and the timeline that they have to take care of that. Going back to the look back period, I think an example is a really great idea. We did play around with some of that language as far as if it's 3 months, if you're new, or 6 months, and it depends on your renewal period. If we were finding it really difficult to get specific without getting confusing. So I think a date, just generic example would be really helpful. So I really appreciate that. And that's anything I'm missing, Anne, or I think those were the high points that I'm really excited to incorporate. So this is all really helpful.
Yeah, no, I think you hit the big ones, but I want to thank you guys. This is how we make this better. And I'm really grateful for a chance just to actually get a workshop it together. So you will see what our kind of final version looks like that reflects all this feedback. But no, this is just kind of the first batch of a lot of communication to come on this. And so we will continue to bring various items to these committees for review and input. And for our managed care partners and provider partners, you all will receive a full toolkit of information from us, and including kind of our approved comms content and phrasing. So that way we're all kind of singing from the same songbook. So a lot more to come on that piece in the months ahead, and really look forward to your feedback if there's resources or questions that you want answered or other materials that we can support with. So thank you all for this time and for a great discussion, and we'll turn it back to you, Casey.
Excellent. Next up is agenda item number 10. We are going to look over the medical respite amendment. So I'd like to introduce Iskara Dearborn, Social Services 2-3 with Nevada Medicaid, to present on this amendment. And we will allow for time at the end of the presentation for any feedback or questions.
Great, thank you so much. Let's see if I can share my screen. It's preparing, so hopefully it works. Can you all see my screen?
Yes, you can.
Yes.
Yes. Okay, great. Thank you so much. I appreciate the opportunity to be able to present today on our 1115 waiver amendment specific to medical respite today. So for today's agenda, I'll kind of ground everybody just a bit on what an 1115 demonstration waiver is. And then we'll specifically touch on our proposed medical respite amendment. And then we'll also highlight some areas where you can provide some public comment, and if you're not ready today to provide any public comment, steps on how to get that comment to us for the future. All right, so for today, first we will review generally just a bit about the 1115 waiver authority. Then we'll present our current 1115 demonstration waiver titled Nevada's Treatment of Opioid Use Disorder and Substance Use Disorder Transformation Project, and how a legislative charge led us to our medical respite services amendment to this waiver. Okay, so 1115 waivers are a mechanism through which states can request exemptions from select Medicaid program statutory requirements like our traditional Medicaid state plan program. 1115 waivers are research and demonstration waivers that provide states with authority to test innovative program ideas for programmatic changes, including eligibility, benefits, delivery systems, and cost sharing. This medical respite amendment is focused on new benefit changes. 1115 waivers must be budget neutral to the federal government and therefore are subject to greater federal scrutiny, subjective review, risk of federal match, and performance penalties, as well as formal evaluation requirements. I know this is a bit of a meaty slide, so bear with me for a bit. So for medical respite amendment, we will be amending our current 1115 substance use disorder demonstration waiver, which is titled Nevada's Treatment of Opioid Use Disorder and Substance Use Disorders Transformation Project. This current waiver is authorizing Medicaid reimbursement for individuals between the ages of 21 and 64 who are receiving substance use disorder treatment in what is known as an institution for mental disease or an IMD setting. Without having this waiver authority, Medicaid is actually prohibited from reimbursement in this setting for this population. This waiver authority is approved through December 31st of 2027. We already have a couple of amendments in process and under review with our federal partners at CMS for this waiver, including requesting the addition to add individuals with serious mental illness, also known as SMI, between the ages of 21 to 64 to receive Medicaid reimbursement for acute psychiatric care in an IMD setting, as well as adding some health-related social needs services. We also have an amendment under review related to adding authority for a single specialty managed care plan to cover all Medicaid eligible children with complex behavioral health needs and children in foster care. Today, we'll be discussing our proposed amendment to add in medical respite services. During the 2025 legislative session, Senate Bill 54 was approved, directing the Nevada Health Authority to seek authority to cover medical respite care as a Medicaid benefit. Nevada will be utilizing 1115 waiver authority to request expenditure authority for medical respite services that are not otherwise covered to individuals who meet qualifying criteria, as well as allowing the state to target this service to a subset of Medicaid beneficiaries, depending on beneficiary needs. Because there's greater scrutiny around the 1115 demonstration authority, there are a significant amount of steps to move through in order to gain approval. There are two paths moving forward in order to operationalize these requests under 1115 waiver authority. The waiver amendment development and approval process with our federal partners at CMS, as shown in the lighter blue, and then the process for operationalizing the new services in the dark blue. The light blue arrow illustrates where we are currently with providing public notice and are eager to receive feedback on our proposed amendment application. As you can see there, there's a lot more work to come with opportunity to receive feedback as we move through development. Once submitted to CMS, negotiations can take many months, sometimes years, to be initiated and completed. So if any of you are familiar with our amendment for adding in our psychiatric treatment for our seriously mentally ill population, we submitted that back in December of 2024, and we're still working with CMS towards approval on that one, so they can take a bit of time. We are also in the beginning stages of the dark blue path. So we're currently working through specific service descriptions, as well as finalizing some proposed payment rate development. Now moving on to our summary of our medical respite amendment, our waiver amendment goals and service description. So the Nevada Health Authority envisions medical respite as a short-term step-down service with the goal of supporting a vulnerable population while controlling costs by providing a safe and clinically appropriate space for individuals to either prepare for or recover from a procedure. Although we hope to gain approval of this by July 1st of 2027, CMS is not held to timelines to approve a Section 1115 demonstration as they are with standard requests like state plan amendment. Our waiver amendment goals include furthering the objectives of Title 19 and Title 21 of the Social Security Act by improving access to high-quality, person-centered services that improve health outcomes for vulnerable populations. Also providing high-quality medical respite services to persons experiencing or at imminent risk of homelessness through reduced utilization of unnecessary hospitalizations and emergency department visits. And finally, promoting access to cost-effective step-down care for individuals preparing for a procedure or recovering from hospitalization. The medical respite care means acute and post-acute medical care and other support services to persons who are experiencing homelessness, who are unable to completely recover from an illness or injury or disease, and who do not require care from a hospital or other inpatient medical facility. Medical respite care includes services and supports to allow individuals to recuperate prior to or following a medical procedure, operation, or hospital stay, including management of care, including evaluation, assessment, care planning, and coordination of referrals and follow-up for medical, behavioral health, and social services, acute and post-acute medical care, behavioral health care, and storage of management and medications. Medical respite services will be provided to Medicaid covered individuals who meet the following criteria. Experiencing homelessness, defined as persons who are transient at imminent risk of homelessness or homeless. Unable to completely recover from an illness, injury, or disease. Those who do not require care from a hospital or other inpatient medical facility. And also preparing for a procedure or recovering following a hospitalization, including an emergency department. In order to become a medical respite facility, a provider must be enrolled as a Medicaid provider. They must demonstrate an ability to operate a modeled medical respite defined by the state, which shall align with the National Institute for Medical Respite Care Medical Respite Standards, also known as NIMARC. Also have a staffing model that includes qualified clinical and non-clinical staff operating within the scope of their practice to meet all components of the model of medical respite defined by the state. Also be staffed 24/7 by qualified healthcare staff who have been trained in things like trauma-informed care, de-escalation techniques, and mental health first aid. Delivery of medical respite services will not be limited to specific regions for providers and will be available statewide. Medical respite will be administered through both fee-for-service and managed care delivery systems, and providers will be responsible for billing the appropriate payer based on the individual's enrollment. Right. So our next steps, Nevada Health Authority is accepting public comments through June 13th. We posted this information last month, and we also held a public workshop on May 20th as well. And again, thank you for allowing us to present on this public forum meeting as well, just to gain as much feedback as we can before we are able to submit to our federal partners at CMS. There are a few ways to provide public comment on this amendment. If you're attending today in person or virtually, we certainly would accept any public comment here. But if it takes a bit to kind of soak in a lot of this information, I'm happy to put the link to all of this information, our proposed application, and even some brief public notice documents to review, just to kind of soak in the content. And please feel free to email our 1115 waivers at mdha.md.gov inbox. And again, we'll be accepting public comment through June 13th. So about 10 more days, and we're excited to receive any and all feedback. I'll put on our screen that inbox again, and happy to open it up to any questions, feedback, comments. I may not be able to answer all specifics today, but happy to take any feedback. What states do when they submit their application is we prepare all of the public comment that has been provided, and then all of our responses to that public comment as well. So it may take us a bit of research to dive into some of these responses, but again, lots to develop. You have a question?
Yeah, Sarah, this is Shauna. I do have a question. I might have missed it, but so for preparing for the surgery, is there a length of time that we're looking at prior to the surgery? And then is there a length of time for after? So 30, 60, 90 days. What are you looking at?
I had a little bit of trouble hearing you. Are you asking what the average length of stay either prior to a procedure or after a procedure?
Yes, that's correct, Sarah.
Okay, thank you. Sorry.
We'll relay it. Yes.
Yes, no, I appreciate that. I think we're still kind of working out some of those specifics. As I mentioned, we're really digging into the specifics around the service description, so eligible providers, more specific definitions around the services, and again, kind of length of stay. There is one current provider that is in Nevada, so we're learning a lot from their experience, but we'll be able to provide those details a bit more down the line as we, again, kind of dig into more research, and then hopefully receive some more public comment as well. Thank you, Shauna.
Excellent. Oh, and to keep us on track, now will be our last piece of feedback to consider or question, and we're going to ask everyone else that has thoughts to submit those through the contact information that Sarah provided up there, just to keep us on track.
Thank you. And Sarah, the only comment I would have is, I would probably recommend to stay away from absolute language. So for example, in your medical respite eligible population, I would probably not say complete in there. I'd strike the language. So to completely recover, because you can be 99% and you're not complete, then you're going to still qualify for this benefit, right?
Mm-hmm. Yeah,
so that'd be my only comment.
I appreciate it. All those little specifics matter, so I appreciate it. Thank you.
Thank you, Sarah. We appreciate all you and the team are doing to move this one forward. Really exciting.
I'll go ahead and present agenda item 11 then. So agenda item 11 is fertility preservation amendment. And I'd like to introduce Yvette Cullen, Social Services Chief 2 with Nevada Medicaid, to present on this amendment.
Good afternoon, everyone. I am hoping that this presentation pops up. Can you see it?
Not yet.
We can share if need, but
Give me just a sec. I think it's working. We have liftoff.
There we go. You're good to go.
All right. Agenda screens. Take a look at the agenda for what we're about to discuss. Go over the background, introduction, talk about the Healthy Futures waiver, which it will be called upon approval, goals, our proposed benefit coverage, eligibility, the projected waiver impact, projected utilizers, total computable expenditures, demonstration, hypothesis, and evaluation, research questions, measures, data sources, and analytic approach, waiver and expenditure authorities, and then I'll ask for some questions and feedback. Waiting for it to respond. There we go. In the US, new cancer diagnoses in women under 50 is on the rise. This is true for Nevada, especially within the last 5 years. Even though the American Society of Reproductive Medicine and the American Society of Clinical Oncology recommend fertility preservation consultation for patients, referrals remain low due to multiple barriers. To provide the medically necessary procedures required by Assembly Bill 428, Nevada Health Authority plans to make an amendment to an already existing waiver known as Nevada's Whole Mouth, Whole Body Connection for Adults with Diabetes Demonstration Project. This demonstration has a 5-year approval period of July 1st, 2024 to June 30th, 2029. Nevada Health Authority is seeking approval from CMS to amend this demonstration to add Medicaid coverage for fertility preservation services by January 1st of 2027. Nevada is excited to join other states such as Utah and Illinois in addressing these barriers. This was made evident during the 2025 general legislative session. Assembly Bill 428 became law and requires the Nevada Health Authority to provide Medicaid coverage for medically necessary procedures to preserve fertility for beneficiaries of reproductive age who are diagnosed with breast or ovarian cancer and receiving cancer treatment that may directly or indirectly cause infertility. This is why the Nevada Health Authority is requesting to change the name of Whole Mouth, Whole Body Connection for Adults with Diabetes, Section 1115 Demonstration Project, to the Healthy Futures, Section 1115 Demonstration Project. This coverage mandate extends to other insurance policies regulated by the state of Nevada as well. The goal of this amendment request is to improve access to fertility preservation services for Medicaid beneficiaries of reproductive age diagnosed with breast or ovarian cancer at risk of infertility due to cancer treatment. The proposed benefit design for fertility preservation services will be the collection of eggs, including ovarian stimulation medications that are not otherwise covered under our state Medicaid plan, and monitoring through pelvic ultrasounds and blood tests to track follicle growth. Egg retrieval through transvaginal ultrasound guided technique to remove eggs from the follicles for freezing, and cryopreservation storage of retrieved mature eggs, which is covered as a single payment for an 8-year period. The individual remains eligible for Medicaid after the 8-year storage period. The beneficiary may request an additional storage period of the same term. The individual loses Medicaid coverage during the 8-year storage period. The stored eggs will remain in storage for the full 8 years. Who would be eligible for these benefits? Medicaid benefit. Oh, I'm sorry.
You're good.
Keep going.
Yeah.
Medicaid beneficiaries aged 15 to 49 years of age with a diagnosis of breast or ovarian cancer at risk of infertility. Investigational or experimental procedures and post-cryopreservation procedures, pre-implantation genetic testing will not be covered, or thawing under this benefit. Cost sharing will not be imposed on the fertility preservation benefit, and the benefit will be available statewide and provided through the fee-for-service delivery system. The projected waiver impact, per the waiver special terms and conditions, the state must provide a data analysis identifying the specific with waiver impact of the proposed amendment on the current budget neutrality agreement. This amendment does not impact the existing budget neutrality agreement for the dental benefit for adults with diabetes. No enrollment limits will be applied to this demonstration, and this demonstration is not expected to increase enrollment projections for Nevada Medicaid. The waiver will be available to Nevada Medicaid recipients based on clinically defined, I lost my place, clinically defined need rather than waiver-specific eligibility criteria. Below, as the current demonstration for dental services for adults with diabetes ends June 30th, 2029, the projections for fertility preservation services align with the remaining demonstration years and are provided below. The actual expenditures under the demonstration will vary, with the figures below representing the amounts up to which the federal government will share in the cost. I'm tongue-tied today.
This class was complicated. Thanks, Yvette.
It's been a long meeting. The Nevada Health Authority, along with an independent evaluator, will submit an evaluation design to CMS using quantitative measures to test the demonstration hypothesis. The hypothesis is that the demonstration enables individuals diagnosed with breast or ovarian cancer who face a fertility risk to preserve the ability to have children in the future. And the final hypothesis research questions, measures, data sources, and analytic methods will be finalized with CMS during the evaluation design process. I will cover the research questions being evaluated. Does the demonstration allow individuals diagnosed with breast or ovarian cancer to preserve their ability to have children in the future? The second research question is, what barriers and facilitators do demonstration participation did beneficiaries experience? Two more research questions. What barriers and facilitators impacted the state's implementation of the demonstrations? What strategies supported addressing barriers? What barriers and facilities did providers experience in delivering fertility preservation services to the demonstration population? The requested authorities for the waiver amendment will be waiving Section 1902 of the Social Security Act, amount, duration, and scope of fertility and comparability, and expenditure authority for fertility preservation services for beneficiaries diagnosed with breast or ovarian cancer. And we've got dates listed for our public notices process. We implemented a tribal consultation on April 8th. May 1st, we published notice of public comment period for this amendment. May 1st through June 19th is a 35-day public notice and comment process. May 27th, we presented at our first public meeting, and then today here at the Medical Advisory Committee meeting. All materials, including the public notice, hearing information, draft amendment application, were made available online at Nevada Medicaid. And the website is listed. I can read it: /program/waivers/oral health demonstration waiver / the public hearing agendas, public notices, and the draft amendment application were also made available on the Nevada Medicaid website on our public notices page. Meetings and public notices will get you there. And the public was invited to submit written comments by email to 1115waivers@nbha.nb.gov or by mail to 9850 Double R Boulevard, Suite 200, Reno, Nevada 89521. Do we have any questions or feedback? I know we're running short on time. Are we going to push it to public comment or?
We'll take a couple of questions and we'll have everybody else submit them through online.
Kehlani Queen for the record. So this is for the preservation of the eggs. Does this also help with the conception process as well when they're ready to utilize the eggs?
It does not.
Oh, okay.
Were there any other questions?
I think my last question, Kehlani Queen, would be, have any other states implemented this? Have we seen anybody else that is currently doing this program?
Yes, absolutely. Utah is a great example. We have looked at other states for guidance and forming our application and how we would look to potentially implement these benefits. And yes, there are other states who've successfully implemented this.
Okay, and then one last question. I'm so sorry.
Okay.
What are the legalities if somebody does end up passing away? Does their spouse have ownership over the eggs? Like, will there be a lot of like legal help with that and legal support?
Well, at this point, we've put together the waiver amendment application. And we would have to wait for CMS approval to actually implement the benefit. And I think further on into the project is when we would get more into the details as far as legalities are concerned. I definitely wouldn't be able to answer it at this point in the process.
Okay, thank you.
It's a question. Yeah.
This is Kim for the record. I was just going to say it's a very timely topic. I don't know if anybody watched 60 Minutes this week, but that was like a major discussion on 60 Minutes was the preserving eggs and how it's become such a huge, almost the norm in younger generations. And so very interesting that it's a hot topic in news right now too.
Yeah, interesting. Yeah, I'm really excited. I'm grateful Yvette for you and the team's hard work on this. Utah has done this, but it's a pretty uncommon thing for states to pursue right now. Especially to have this procedure be totally no cost to patients is really incredible. So I'm excited about this. I'm excited to see what we learn. And there's a lot of details we'll kind of encounter through that process. So thanks for guiding us through there, Yvette. We appreciate you.
No problem. And then, of course, if you'd like to contact us, you can utilize 1115 waivers at nbha.nb.gov. And of course, our website always has a plethora of information. Thank you so much.
Thank you. And that brings us to agenda item 12, which is the MCO marketing materials. And I think that there are a number of presentations here. So I'd start with David Kraus from Anthem Blue Cross Blue Shield. David, I don't have your official title.
Absolutely. David Kraus. I am the I'm the NV market manager for Nevada. Thank you.
Excellent. Do you want to present? Do we want to do this? Do you want me to introduce everyone, or do you want to present first? You got it?
Oh, I can just jump in.
Perfect.
So, first of all, good afternoon, friends and neighbors. It is lovely to see everybody. What a bunch of wonderful information that we've already been hearing. It is my privilege to present to you our marketing materials for this upcoming open enrollment. Again, my name is David Kraus, and let's get cracking. So we are proud to launch our More of What You Want campaign. The campaign is designed to simplify access and show the value of Medicaid benefits by highlighting our commitment to high quality care and meeting members where they are. Our goal is to position our brand as a trusted choice that meets the needs of our community. It's important to note that this campaign will be running in English and in Spanish. And I'm going to take you through a little bit of the campaign, which is going to include videos, social media ads. It's going to have web banners and radio. Thank you. So here's some of the images that we're going to be adding to our very robust cache that we've been using. We've been doing this for a while. So you can kind of see a little bit of what's going to be coming. Starting with, we have these 30-second videos that are going to be the television versions. So you're going to be seeing these. Our first one up is you can see an expectant mother who is working a night shift, and she is using virtual care. We can see in the next one, starting at number 4, a young man who is meeting with his doctor, asking about his cochlear implants. And it states that he wants to hear everything. Moving to number 8, we go over to a family going to a resource fair before school, highlighting the community support and everyday needs. And finally, we have a gentleman meeting with his doctor, and he's stating that he wants to have a doctor who wants to get to know him, okay, who gets him. Now we're visiting back again with our hardworking night shift mother-to-be. So you can see here again, meeting with her virtual physician. This is a 15-second video now, so it's a shorter version. Here is the second version, the 15-second version of the community support. And finally, the little 6-second videos that we get in between of our Spotify when it's going through with the gentleman who's looking for a doctor who understands him and gets him. Here we can see a couple on the left side and central. We can see a couple of the banners that you will see when you're navigating the internet. And on the right side, you will see the radio ad, which I'll read a little bit of it to you. So I did, I'll be honest, we had the World Cup USA playing and the Golden Knights. So I got a little extra bass in my voice if you're hearing it. So if you meet me and I sound different, that's why. So he's saying, I want to skip the waiting room. I want to help finding a therapist. I want care I can count on when I'm pregnant. I want doctors close to home. I want my kids to have what they need to grow up healthy. Get more of what you want in Anthem Healthcare. With a Medicare plan from Anthem Blue Cross Blue Shield, you get virtual care, a wide network of doctors, and community support of everyday needs. Never go out alone. That's our anthem. Okay, that's our radio. That's all I'm going to be doing for that stuff. Heading over, we're meeting with the hardest working person on the night shift. She is back again, and this is going to be a 15-second, it's the same ad, but it's going to be going in on our social media. So it's what it's going to look like. We have our family visiting the back to school in another post. So you can see the breakdown on the right-hand side with the mom just wanting her child to be a kid. You can see on the left exactly what it's going to look like on your phone. Finally, we have our 6-second ad that's also going to be for our social media with the gentleman visiting with his doctor. Okay, we have our demand gens, which these are the little ads that you get where it'll say something along the lines of Medicaid with more of what you want, or choose the best Medicaid plan for you. And you select it, it'll take you to somewhere where you get more information. This is what it looks like on your phone, in case you haven't been on your phone in the last 15 minutes. Okay. And that's everything that I got for you guys. Everyone, is there any questions? It was, I know we're good on time, so I'm happy to be here for you if you need it.
Perfect.
Go Knights.
I don't see any questions.
Thank you, sir. Thank you, friends. Look forward to seeing you guys out there.
Perfect.
Thanks, David.
Thank you.
All right, thanks, David. And with that, I'm going to call up Courtney Tremblay, Senior Director of Brand and Advertising, and Michael Litchin, Manager of Brand and Advertising for CareSource.
Thank you. This is Dr. Tracy Green. I serve as Chief Medical Officer. I think I will get started for the CareSource team and then turn it over to my colleagues. Next slide. So very briefly, I just want to share, as you all know, that CareSource has more than 35 years of nonprofit managed care experience. And our mission is to make a lasting difference in our members' lives by improving their health and well-being. And we feel that our marketing campaign really leads and feeds to our mission. Next slide. Our core values really are around similarly dedication to our community and the fact that we show up to serve our members. Our goal is to become a part of our communities, helping members to greater self-sufficiency and independence. And our priority is really to help people live healthier, happier lives within the communities that they are living and working. Next slide. I want to just introduce you to our key personnel, our plan president, Jamie Pu'u, myself, our chief medical officer, and Nam Pham, our chief operations officer. Next slide. Courtney and team.
Thank you, Dr. Green. I appreciate the opportunity to chat today. I'm Courtney Tremblay, for the record. Again, I appreciate everyone's time and the opportunity to work through how CareSource's approach to marketing. Next slide. So we're executing that through a statewide strategy, but we tailor how we show up based on the communities that we're trying to reach. CareSource serves members across all service areas, including rural communities. So that really shapes how we think about our communications. The messaging, the visuals, and the call to actions reflect differences across geography, demographics, and community needs, making sure that the information is accessible and relevant to how people actually receive it. And importantly, everything does go through the required reviews and state approval processes to ensure it's clear, accurate, and not misleading. Next slide. To support that effort, we leverage a mix of channels, including digital, TV, out-of-home, radio, and community-based outreach, based on what will be most effective to the populations that we are targeting. The goal is simple: to make sure the information is available across different touch points so that people can access it in a way that works for them. Next slide. Our focus is on prospective Medicaid eligible individuals, people who could be exploring coverage or re-engaging with the process. We know that this can be an overwhelming time, especially for those navigating Medicaid for the first time. So we design messaging to feel simple, clear, and helpful. And in our estimation, it's really about helping people understand what's available and how to take the next steps. Next slide. In parallel, we are engaging providers and community organizations. These are the people that guide those decisions every single day. And for that guidance, we focus on clarity and consistency, making sure they understand how to connect individuals to coverage and resources. We use a variety of channel strategies and tactics like connected TV, out of home, and linear broadcast to reach those audiences. Next slide. This slide outlines how we manage consistency and compliance as materials are developed and adapted. We maintain the intent of approved messaging while allowing flexibility across formats and channels. And where needed, we transcreate materials so that they remain culturally relevant and understandable while making sure that we stay aligned to the approved content. Next slide. From a messaging standpoint, our messaging is really grounded in making the information feel accessible and clear and relevant to the people we're trying to reach. We focus on helping individuals understand not just coverage, but how to access care and support. So if you go to the next slide, you'll see with Care That Connects, this comes through in this platform, which again is created specifically for Medicaid eligible recipients. Next slide. Or simply put, care that connects reflects how we show up as a partner, helping connect people to services and resources and care. And it's carried through all relevant channels, including print. Next slide. More broadly, reimagining healthcare in Nevada is how we're positioning CareSource in Nevada, focused on improving access and helping people navigate the system. Next slide. Our approach is about reinforcing a more connected, community-based approach to care. The goal is to align our goals with improving long-term outcomes. So you'll see that in the messaging and in the visuals. Next slide. As we shift to the visual assets, what you'll see here is representative sampling of our creative assets, but not the full set. Next slide. These examples on the screen show branding and visuals are applied consistently across formats while adapting to the different channels. Next slide. Again, what you're seeing here on imagery is a representative sampling of photography, but certainly not the full set. In full execution, our photography is designed to reflect people and communities we serve across Nevada. That includes representation across urban, rural, and frontier communities, as well as tribal LGBTQ+ populations. We build that in from the beginning to ensure that materials feel relevant and representative while remaining aligned with accessibility and compliance expectations. Next slide. Before I pass to my colleague, Mike Luchent, to walk through the examples of the marketing materials, I'll just pause for any questions about this first section.
Courtney, I was just going to give you a shout out for a picture of one of my favorite trails up in Tahoe. I see East Shore Trail in one of those pictures. So thank you for including content of places close to home for all of us. I think that really does resonate. So appreciate that.
You bet. We're where you are. So thank you for that feedback. Okay, Mike, I'll pass to you. And thank you for your time.
Thank you, Courtney, and thank you, everyone. Appreciate your time this afternoon. So how do we bring this strategy to life? We bring this to life through our advertising materials as well as our marketing collateral. We'll start with some of our advertising materials. While there's no substantive change in our advertising content year over year, you will see examples that are, as Courtney mentioned, not exhaustive of every bit of creative that we'll be doing, but do capture that approved content that we've utilized. Here's a sample of an out-of-home billboard in English, and here's one in Spanish as well. So again, these will be running statewide, serving both English and Spanish populations. Additionally, we also have sample ads of some digital ads, some digital display, some of our posters, and representative of our TV spot here on the bottom right. Again, none of this is updated creative. It is representative of the larger suite that we have ran in 2025. Here's a sample of our visual of our digital ad in Spanish on a mobile device. It rolls through those different frames and then brings you to the call to action on the far right. Moving into new sales collateral, marketing collateral, one of the key pieces we want to present is a sample event invite. This is a template that's used by community marketing reps in the field to invite consumers to the events in the community where those consumers may be. The community marketing representative would customize this with the event details, allowing them to really bring a personal approach to those folks where they are. Next, we have our how to choose sample insert. This is available in not only an insert that could be placed in a brochure, but also a postcard form as a standalone piece. And essentially, this outlines the process that consumers can select their Medicaid plan. Next to that, we have our hotline card, which is going to be about a business card size piece, which just directs the consumer straight to the Nevada site or phone number for enrollment. And the QR code will go to the CareSource site for more information. Next, we have our marketing poster. This will be high-level value-added benefits information. These will be on-site at events and locations where our consumers may live, work, and play. And we have taken the state's requested feedback to update the order of these value-added benefits and ensure that the
It feels like it is still here clinging to you.
Hello, for those
Pardon me?
online, can you please ensure that you are muted? Thank you.
And then finally, we have our yard sign. And so this is high-level information for consumers, similar to the hotline card, drives them to the Nevada Medicaid site and the hotline. And also the QR code does go to the CareSource site for more information. This can be placed at community partners, locations, etc. And that's what I have. Would anyone like to ask any questions?
Kehlani Queen, for the record, I enjoy the community event that you guys are putting on for consumers. I think it would be really helpful to put on one for providers as well, in specific fields in Clark County, like maternal health, so we can all kind of mingle and get to know the CareSource representatives out here and get to know each other and the work that we do in the community.
Thank you for that feedback. That's something that we can certainly pass along to our provider engagement team.
Thank you. Excellent. And for the sake of time, we'll hold all remaining questions and comments until later agenda item for roundtable discussion.
Thank you all.
Thank you.
Perfect. Thank you. Next up is Joya Alexander, Senior Director of Marketing for Health Plan of Nevada.
To me, so it's complicated for being in person.
We're glad to have you.
So I guess I'm. Yes, there we go. Would you be able to pull that? Yes.
Yeah.
There we go. Perfect. Thank you. Very short with the time frame we have. Just got a couple slides, not a lot of changes over last year. So my name is Joy Alexander, and I'm the Senior Director of Marketing for Health Plan in Nevada Medicaid. And I'm here to present our 2026 MAC marketing submission. Next slide, please. Very short, just a little level set. Our plan name is Health Plan in Nevada Medicaid. We serve in Orford, Clark County, and we've been serving Nevada Medicaid very proudly for 29 years. Please. So these are our marketing assumptions. We pretty much included these year over year. Not really any changes. We did add just a call out just to make sure that there is a collaboration. If Nevada Medicaid required any change to marketing asset or wanted us to take something down, we absolutely would do that as quickly as possible to accommodate that request. But if anybody, when we get to that point, if anybody has any questions about this, please let me know. Next slide. So this is how we use the variable data that's included in the marketing assumptions. This is an open enrollment banner ad. So you can see in the top light blue box and the bottom light blue box, that is approved content from a previous submission. And then you'll see how it's actually placed into an ad. Gives us the flexibility for the type of marketing asset we have, whether it's a billboard, a web page that you can include a lot more content, a small digital ad that just can really have your logo or your plan name. And it gives us that flexibility since we only have the opportunity to get this feedback and this approval once a year. Next slide, please. These are just examples of our brand assets and examples of collateral. So we've got a flyer. We have some digital ads on your right. And what we're doing is we're trying to increase our illustration library and trying to really get a visual representation of what we're including in the copy to help people with comprehension and to understand a little bit more what they're looking at. So hopefully next year I'll have a whole slide deck of illustrations that I'll be able to share with you. Next slide, please. And as the others, we have a slide with just a sample of our imagery. We have a huge library of images, and each year I just try to bring a new set that everybody can take a look at of what imagery we use, and that we're making sure that we have it so it represents the members we serve. Next slide, please. And then we have just two slides of new content from last year. So these are phrases that we would be using in our advertising campaigns and marketing collateral. And of course, when we get to that point, if you have any questions about how it would be used or what we're trying to do there, you're welcome to ask me. And then it's just one more slide of content. And that's all we really have this year. Pretty minimal.
I have one question, so super helpful.
Yeah,
one of the languages terms that you were adding is person-to-person contact. Is that really about kind of the care and services or more care coordination, or what's the kind of?
It's actually both. So it can be person-to-person contact where we're out in the community. We have, and then we also have health education and wellness. We have one-on-one consultations. We have person-to-person information related to that. So it really kind of goes across everything, and it could be tied to something specific related to community outreach.
Love it. Super helpful context. Thank you. Sorry,
I know that was really.
I wasn't supposed to ask a question. My apologies.
So,
Forgot.
No, should I just, because we're gonna ask questions later?
We'll do questions.
Okay.
Yeah, a little bit later. Unless you do run Medicaid, you do what?
All right, excellent questions coming up, but next up is Kim Gahagan, Director of Plan Marketing for Molina.
Thank you so much. Do you want me to share the screen or?
I can share them. Kim, I already have them up.
Okay, that'd be great. All right, so if you could just, so Kim Gahagan, I'm the Associate Vice President of Growth and Community Engagement for Molina Healthcare of Nevada. This is the perfect slide. So really just to give an overview, Molina Healthcare's open enrollment strategy for 2026 supports Medicaid growth and retention through coordinated outreach, education, and member support in an integrated model. So the focus is on helping eligible Nevadans make an educated choice for a plan and to stay covered. And then Molina's overall approach is partnership driven. So providers and community organizations, we prioritize trusted local channels to reach our eligible populations, community events, grassroots outreach, partner enabled education. And when I say that, it's things like our community-based organization. We take lessons learned and feedback from members and providers in things like the CBOC and our member advisory committee and incorporate those in our materials each year so that they can get easier to navigate for members and in more simple language. Molina provides culturally relevant, accessible materials, of course, in Spanish, which we know is required by the contract, but Molina will also translate into other languages as requested. We also emphasize the family and caregiver support because we know these are crucial components for the Medicaid members that we serve. And then if you just want to flip through some of the next few slides, it's going to show some of the actual materials. So keep going through. There's going to be printed materials on there. There's going to be screenshots of the website. There's going to be screenshots. You can keep going of the portal. Really very few changes from last year, just minor changes. You can keep scrolling. So these are the materials. Keep going. Perfect. And then if you want to go to slide 17, where the value-added benefits are. Oh, back up one more, sorry. Right there. So we have decided to incorporate retention into the open enrollment materials this year because of the emphasis on redetermination. It provides us a chance to discuss redetermination upon impact with members. So when we're engaging with them at community events, we're also talking about redetermination on a broad topic. And then obviously if they are our members, we can help them in more detail, but really incorporating that every chance that we get. These materials for redetermination and retention, if you want to scroll down to the next slide, they contain information specific to members, one more slide, but also information that's helpful for our community partners and our providers as well, just general information about redetermination. We know with all the changes coming up, with the navigator grants that are coming out, we want to empower our partners to really feel comfortable about having these discussions as well. And then if you'll scroll down a few more slides to the value-added benefits. One more. So Molina recognizes that the value-added benefits are part of our value proposition or differentiators for Molina. So the value-added benefits support health, they support social needs, they include things like preventive incentives, maternal support, and then wellness programs. So just to highlight a few that were launched this year that have been really well received, the gym membership, $100 towards the gym membership or at-home fitness equipment. We have maternity bundles for completing a notification of pregnancy. They get to choose from one of 3 bundles. We have the $100 tobacco cessation. And coming in July, launching July 1st, we're going to have a $100 daycare benefit for a half-day emergency type drop-off for daycare. So when parents have maybe a babysitter that's sick or someone cancel, then they'll have this option to utilize for the daycare. So we're really excited to launch that benefit in July. If you want to scroll down a little bit to the photography that's toward the end, the last couple of slides. So in closing, this marketing plan really reinforces Molina's role as a trusted partner supporting access and continuity of care in Nevada. So these final slides just show some of the new photos for 2026 representing the diverse population that Molina serves. Thanks so much.
Thank you, Kim. And with that, I'm going to proceed on to Matt Pumonte, Senior Manager of Marketing at Silver Summit.
Thank you. Good afternoon. I'm going to share my screen real quick. All right, is everyone able to see my screen?
Yes, we can.
Yes.
Perfect, thanks so much. Good afternoon, Chair Mediwala, members of the Medicaid Advisory Committee, Nevada Health Authority, and fellow MCO colleagues. My name is Matt Pumonte, and I'm the Senior Manager of Marketing with Silver Summit Health Plan, and I appreciate the opportunity to present our Health Plan's 2026 marketing materials. Our approach is centered on a simple but powerful idea. Every health journey is a story worth telling. Through real member experiences, we demonstrate how care, access, and community come together to support healthier futures across Nevada. Our members are at the heart of everything we do. They shape how we communicate, how we design our materials, and how we build trust. All materials are created with accessibility and cultural respect in mind, written in the new requirements, and are culturally adapted so all members feel understood. In 2026, we're launching 3 new messaging campaigns: housing supports and services, school health services, and workforce development in healthcare, expanding care beyond the doctor's office to support our members where they live, learn, and build futures. The messaging is built around whole person care and informed by real member experiences, focusing on stability, opportunity, and access. Housing stability plays a critical role in health outcomes, so this messaging focuses on informing members on the support and on the community-based organizations that support safe, stable housing so they can focus on their healthcare. Our messaging emphasizes stability, safety, and support using clear, familiar language such as help finding a home, support with moving, and help staying housed. By clearly signaling that housing-related support is available through coordinated care with our community partners, members can quickly understand how housing stability connects with better health. School health services are designed to bring care where students already are during the school day, making it easier for families to access healthcare services their kids need without the added stress or missed class time. A dedicated school health services liaison helps connect schools, families, and providers, and educates families on Medicaid benefits. Messaging emphasizes convenience, connection, and family involvement using phrases like care at school, working with your child's doctor, and parents are part of the decision. The goal is to help students stay healthy, in class, and ready to learn. Workforce development in healthcare supports members and community partners who are pursuing careers in healthcare with a focus on addressing workforce shortages, especially in rural and behavioral settings. Messaging focuses on opportunity and growth using language like grow your healthcare career, support for training, and help moving forward. By investing in people and career pathways, Silver Summit helps strengthen local access to care while supporting long-term community health. All 2026 marketing campaigns reflect our ongoing commitment to cultural competence, accessibility, and consistency in communication. Materials are written at a 6th grade reading level and adapted with cultural context, not direct translations, to ensure clarity and relevance. Approved language from prior years may be reused or adapted to support continuity across campaigns while maintaining compliance. Imagery is selected to reflect the Medicaid population we serve, representing diverse ages, cultures, and lived experiences. We will continue to lead with Here for Your Health, making small, intentional updates to align with our messaging. Every asset was designed to reflect a real member experience, so our messages feel genuine, familiar, and rooted in everyday life. Thank you for your time today and the opportunity to share Silver Summit Health Plan's 2026 marketing materials. We welcome any questions at this time.
We've got time for one question.
If anybody has it? I've already used mine.
Excellent. Not seeing any questions here. Are there any online, Jonathan?
No, I do not see any.
Excellent.
Thank you so much.
Thank you so much, Matt. Thank you to all of the MPO presentations. We'll keep going on to agenda item 13, where we are going to discuss the annual report. The MAC and BAC support staff have drafted the MAC annual report using previous meeting minutes, discussions, and presentations. The report outlines the MAC's activities, topics discussed, recommendations, and the state's responses to those recommendations. You will also see references to the BAC, as one of the requirements for this report was to include BAC activities, topics discussed, recommendations, and state responses to those activities specifically. Because BAC members have participated in MAC meetings, this allowed for a really cohesive discussion and alignment across both groups. Bringing that into agenda item 14, we'll open it up for discussion. Are there any questions or comments on the annual report?
Be back.
You just clarify if today's meeting goes into the next report.
Yes. Do you want to speak to that super briefly so folks here know too?
Oh, yeah, absolutely. This report was comprised of information of the previous 3 MAC meetings, not including today's meetings. Today's will go on to the next annual report. Right. I'd like to call for a motion to approve.
Motion.
Wait a second. We have a second, and we will just do an audible. Everybody in favor, say aye.
Aye.
Anybody opposed? Motion passes. Moving right along, we are at agenda item 15, where we will have a roundtable discussion. The MAC can use this time to expand or finish any discussions that we had on any of the agenda items previously. This is also where you have pressing questions for any of our MCO presentations that we ask you to hold on to.
Kehlani Queen for the record. So I got to meet with DLAC, which is Doula Learning and Action Collaborative here in Nevada. So it is basically a doula-led institute for Medicaid innovation. So it's a 3-year initiative that will help empower the community and increase access to community-based doula services for families with Medicaid coverage. So they gave me this QR code to give to possibly the MCOs to pass out to providers, OB offices, and midwifery care clinics to see what their feedback is working with Medicaid doulas, if they know about Medicaid doulas. I'm seeing a lot of OB offices don't know that it's a thing. So I think it's important to get that out there and how we can better assist the maternal health thing that's going on here in Nevada. I will also say one more thing that I've been noticing as a Medicaid doula here in Vegas. This year, I've noticed an increase on cesarean sections unnecessarily. So people getting kind of pushed into that. It used to be that they were only allowed about 24 hours of time to give birth before they're getting pushed into cesarean sections. I've seen it recently where Medicaid recipients are only given about 12 hours before having to get an unnecessary cesarean. So that would be an elective cesarean. So I've noticed there's been a big change in the level of care in our hospital systems. And this is something that I've communicated to other Medicaid doulas here in Nevada as well, and they've noticed the same thing. So I think that's really alarming because we already have really low maternal health. I think we're like 47 or 48 out of 50 in the entire country. So I don't think an increase on unnecessary surgery is going to help those statistics. So I thought I would just kind of pass this to you guys, and then maybe if you could put this in the website into the chat. I don't know if there is anybody in the maternal health space that's online or a part of the MAC meetings or the MAC board, but if they could also take the survey, I think that would be really helpful as well.
Just want to share, thank you, Kehlani, for sharing that and for all the work you do as a provider. It's a really helpful piece of feedback on the trend that you're seeing and something that we can have our analytics team take a look at from our Medicaid claims data. It's a little bit farther behind often the experience that you're seeing right away. So it'll be helpful for us to see how that's trending, but definitely appreciate we have a long way to go to get to 47th, right? That's our first step and then we'll keep going. So thank you for all your help and happy to pass along some connections there. And if others from our MCO teams want to chime in there too, we welcome any thoughts, but I appreciate you raising this today.
Thank you.
I have something to add. I know that future public workshops will also go into greater depth for HR 1's implementation, but I just wanted to offer the recommendation of being specific with the eligibility providers that can assess functional capacity for those that can or cannot work and what those limitations are. It's such a great space to use physical therapists, occupational therapists, speech language pathologists, in addition to primary care and some of those traditionally resourced physicians. Since we have a shortage for all providers, maybe we can just divide and conquer and be more inclusive so that way that can be faster for beneficiaries to access the type of documentation that they need to continue to get benefits.
Helpful. Thank you for that feedback. And yes, definitely will be a topic of public workshop, but something we can take back now. Appreciate that.
All right. Are there any other topics for discussion anyone wants to add or any questions?
Kehlani Queen for the record, I think my very last ask would be for the MCOs again. So I got to meet with Silver Summit. They were extremely helpful with reaching out to doulas out here in Clark County and asking what they could do to push out the doula benefits to the community so that they're aware that that is a thing. I think it would be really helpful for Molina, HPN, and all the other benefits to get in contact with doulas as well and ask how they can raise awareness on Medicaid doulas. I believe there's 36 in Clark County, so that's a good amount of Medicaid doulas. However, not a lot of people are utilizing that benefit, so.
Seeing no more discussions, we are now at agenda item 16. Public comment. If you would like to make a public comment, please raise your hand or type public comment in the chat or enter the last 4 digits of your phone number and your name will be called on to begin. Please state your first and last name at the beginning of the recording and you will have 3 minutes to speak.
Hi, Chair. Excuse me. Hi, Chair. We had a public comment from Alden. His question was, or is, how is Medicaid prepared to handle the increase in renewal applications?
I'm happy to take that one. So I would say from our perspective, it's actually not an increase in the number of applications because that will be the same. People will be going through the same renewal process. It's more so an increase in probably the paperwork and complexity of those applications. So we're working hard to ensure that our team and sister agency at the Division of Social Services, all of their staff are well trained and have all the information they need to go through that process and answer questions. We're also going through a broader modernization effort to move a lot of our Medicaid enrollment to our online exchange website. So that will take a lot of the load off of our existing caseworkers and they can use more of that time to spend supporting our patients that have to go through the work requirements process. So definitely something we're working very closely, and I know Administrator Robert Thompson's on the call, and I'm working very closely with him and his team to ensure that all of our teams have capacity to move through this. And at this time, we're feeling to be in a strong place to be able to address those questions. But Robert, if there's anything else you'd want to chime in and add, you're welcome to. Otherwise, happy to speak to any further questions, Alden, and I appreciate you raising.
No, Robert Thompson for the record, our staff are used to doing these, so the complexity isn't any different. It's just the volume, and we are working right now to adjust resources to make sure we can handle the volume.
I think we just had one more for the member notices. Is the draft notices available online to non-MAC members?
I'm not aware that it is at this time, but we will be posting these materials to our HR1 website once we've kind of incorporated this feedback. And if as a non-MAC member, if you had feedback on the notices today, based on today's discussion, we always welcome that to our Medicaid email inbox or to our community and provider engagement inbox. Wherever you send it, it will get to us, we promise, and we'd be happy to reflect your feedback. So thank you.
Jonathan will go ahead and throw that email in the chat, and you do see a hand raised as well.
Nadis, you can go ahead and come off mute.
Hey, good afternoon, everybody. I'm Nadis Venegas-Morales with Silver Summit Health Plan. Kaylani, if possible, can you add you said you had a QR code for that survey that you want the members to complete. We can certainly help pass that out for us to gather information about their perception and their knowledge of doulas. We definitely can help with that at Silver Summit. The second comment that I wanted to make regarding doulas is we do have a toolkit that's in the works that is specifically for the doulas to help us bring more engagement on the part of the doulas to the health plans. And we will definitely be glad to share that toolkit when it's complete with this board. If you would like that, just let us know.
Awesome. Thank you so much. I appreciate all the work that you've been doing for doulas out here in Clark County. Well, there's a comment from Desiree as well. Looks like a good question.
Yeah, for comment, would herbal medicine ever be considered on Medicaid?
Yeah, thanks, Desiree, for the question. So any benefit at all that would be an expansion for Medicaid has to go through a process to get legislative approval and to allow us to be able to have funding to cover it. And then we go to the federal government for approval on their end. I'm less familiar with exactly what the herbal medicine component would entail. That would likely require an 1115 waiver, kind of like what Sarah and Yvette were speaking to earlier, where it's a process to ask the federal government to allow us to cover something that isn't already covered or typically covered by health insurance. So If that's of interest to you, definitely recommend the legislative route to pursue coverage is always the best path to go, and we're happy to speak to any questions you may have on that. But again, that would be kind of step one, is getting legislative approval and funding, and then we would move forward with the process to figure out whether and how the federal government would approve that as well. So thanks for your comment.
Kaylani Queen, I think that has been considered or is in a covered benefit in Medicaid in certain states, maybe New Mexico or Arizona, where people can go to like indigenous medicine workers and get care.
Thank you. Yeah, so that's a great, thank you for that connection. And specifically to traditional healing for our tribal communities, we are actually pursuing a very similar federal waiver like what they have in Arizona and New Mexico. And we'll, using our rural health transformation funding, that's something that we're doing and starting that process right now. So if that's of interest to this committee, we'd be happy to bring more information. We'll be working to submit that, like the other two waivers we talked about today, to our federal partners in the coming year, and believe it's a really valuable way to support our tribal community here, and we're really excited about it too. So if that's of interest, we'd be happy to speak more to that.
I would love to, and I would love to be able to support those tribal communities in the rural area as a doula, and kind of get in contact with the midwives that I know, because I know they may not have access to hospitals and things like that. So I am happy to help with how I can.
Thank you. I appreciate that. And we can maybe add that as another agenda topic for later on. Yes.
I guess my question is more like, because there's a lot of evidence to support herbal medicine, and a lot of elderly patients are resistant to getting their prescriptions filled in the pharmacy. So, but they will do herbal medication, and there's a lot of studies to support that some of them work. So that is something that and to support the tribes, like they said, there's a lot of benefit to this. So maybe trying to get something in the works. I know it takes a while, but to get something to support something like this, like an herbalist, or even something like a hybrid, like pharmacist hybrid or something like that, to support this type of path to go down. So we can bring in the tribes, we can bring in herbal products that can help elderly people that are very resistant to actual Western medication that has evidence to support it.
Thanks, Desiree, for that additional detail. So it's helpful to hear it's both the kind of traditional healing component and more broadly, various herbal remedies. So yeah, I think same process would apply here. It would be kind of working through to identify whether a legislator would be interested in bringing that forward and working with the provider community on that piece. So from our perspective at Medicaid, we are neutral on all legislation. That's not our budget request, but we're happy to support from a technical assistance perspective. If you have any questions as if and when you're able to move through that process on what that would look like in terms of Medicaid coverage.
Nahibi Flores Rosivas, for the record, I'd just like to make a public comment regarding our Medicaid Advisory Committee and our Beneficiary Advisory Council. We do have a few members who will be, their terms will be ending at the end of this month. And so we are currently recruiting for more members on both committees. And so if you are interested in applying for either the Beneficiary Advisory Council or the Medicaid Advisory Committee, we will go ahead and throw the application in the chat. And then for those members who do have terms ending, although you cannot serve consecutive terms, you can reapply in the future. So if that is of interest, we encourage you to do that. So thank you so much.
I just want to add and echo my thanks for those that are reaching the end of their term. We're so grateful for your time and thoughtful collaboration. I know these days are long, but they're truly some of my favorites of every quarter, and really give us energy and the feedback we need to make this program better. And I'm really grateful. I know you're taking time out of your days and your work to be here, and we don't take that for granted. So please do, if you're not formally part of it, we'd love for you to be. Please do consider applying. And if folks have questions, I'd also like to give a shout out to Nahibi and Jonathan and our full support team who have done incredible amount of work to stand this up. Our first ever Mac and Back, as other states are doing across the country, but I think ours is best. And thanks in large part to a lot of their good work. So thank you both for all that you do.
Wonderful. Okay, seeing no further public comments, that brings us to adjournment. We will go ahead and adjourn this meeting at 3:35 p.m. on Wednesday, June 3rd.
Wonderful. Thanks all for joining us online. We appreciate it. Take care.